Most of the time we're not aware of it, but as we go about our daily lives, we create a trail of data and masses of it, a digital record of where we are and what we're doing. And as computing power increases and gets cheaper, we can gather and analyse this information on an ever grander scale. We live in what's being called the era of big data. Unlocking the messages held within this mass of raw data could help us to lead lives that are more efficient and save money, but could also reveal information about each and every one of us that's sensitive. Many of us might not care too much about some of the data that's collected on us, say what we buy at the supermarket or how we use public transport. But when it comes to information about our health, many of us see that as so personal, we want to be sure it's kept especially safe. The government thinks the health and wealth of the nation could benefit if we were all a little more open with our data. So the question is, how far are we prepared to trade our personal information for the promise of a healthier future?
I'm passionate about this because I see this as being quite a dramatic change in the way that medicine is likely to evolve.
Given that a lot of this information is personally very sensitive, it's got to be used in the right way. You've got to be honest with people about what's going on, and you've got to give people the opportunity to opt out.
The grand bargain that the government's offering us is that if we give them our DNA, then they're going to revolutionise healthcare. And it's not clear that the British public is actually willing to accept that bargain.
The government already seems pretty convinced. At the end of last year, it launched a big data project for some of the most intimate of personal information, the DNA readout of 100,000 Britons suffering from rare diseases and cancer. It's a colossal sequencing effort because not only does each patient have a unique DNA code, but so do their cancer tumours. Doctors need both to identify the most appropriate treatment.
It's the future for healthcare because we want to crack cancer and the DNA database can help us to do that. But we also want to keep Britain at the absolute forefront of biotechnology, of pharmaceutical industry. We can be a real world leader in this.
So aside from highlighting British innovation and attracting investment, the idea initially is to help people who are already sick. That's because we know, for example, that some people's cancer tumours will respond better to one drug rather than another. For the rest of us, the argument goes, if enough people are on the database, trends will become clear. So we could be more confident that our personal DNA readout can be checked against those trends and might warn us we're more at risk of certain diseases and do something about it, like changing our lifestyle or getting screened. And we might be able to avoid drugs known to be toxic in people that carry a similar genetic makeup to ours. The data at the heart of this project is the DNA double helix. It's made of 4 chemicals, essentially a code with 4 letters. The string of letters that spells out a human being is huge. It took about 8 years and cost billions of dollars to unravel the first human genome. But now, the computer technology that made that possible is far more powerful and cheaper. It now takes a little over a day to sequence a person's DNA, and though it's not yet possible, there's talk of a $100 price tag.
To be honest, cost is everything. So I wasn't talking about this 2 years ago. I wasn't even talking about this 1 year ago, because the cost of doing this was such that it would be an enormous burden to do it at scale. But the cost of sequencing a whole genome, as you know, has fallen by more than 100,000-fold in 10 years.
Andrew Wilkie works on rare genetic disorders. He uses the power of DNA sequencing to identify genes behind craniofacial disorders. His work provides families with answers and can help them to make decisions about having more children.
I run a small lab with about 4 staff working in it. And in the past couple of years, we've identified as many new genes in my group of disorders, craniofacial malformations, as the entire world achieved in the previous decade. So, you know, that's obviously spectacular progress, and also, of course, it represents incredibly good value for money.
The NHS already has world-class big data projects in place, notably a system that enables scientists to carry out research on our clinical information, once anonymised. And there are genetics research databases too. But the idea of bringing all of this together is to create a much more powerful source of data, so that scientists can better understand disease and people might get drugs that best suit their genes.
One of the things that we do have in the UK is we have scale. And the truth is there's lots of data systems in the world, which are 5 million people here and 4.5 million people there. Ontario's got one, Scotland's got one, Australia's got one. Some of the healthcare systems in the States have got them. The great thing about the UK, and particularly the English NHS, is 50 million people. And it's at that scale that you're probably going to have the power to detect all kinds of things that are very powerful in terms of the management of disease and have quite a profound impact.
It may be some time before there are enough people signed up to realise the promised power from genomics in the UK. In Iceland, they've already tried to harness its potential, albeit on a smaller scale. In the 1990s, a company called Decode Genetics set out to bring together the DNA code and medical records of the country's entire population. Again, the aim was to try to identify genetic risks for common diseases, but the project proved controversial over privacy and data protection issues, and the Icelandic Supreme Court questioned its legal basis. The government boasts the UK will be the first country to introduce DNA sequencing within a mainstream health system, but that's part of what worries critics. Though the plan is for the information to be anonymised, computer security expert Ross Anderson says medical data is hard to protect because it's so rich in information.
The NHS has traditionally anonymised data for research by removing people's names and addresses, but by leaving on your postcode and date of birth. Now, this doesn't really give you any protection at all against a competent adversary, because postcode plus date of birth is enough to identify about 99% of people easily. What's more, there are all sorts of circumstances that will identify people uniquely. The fact that a certain person got a certain treatment on a particular day, for example, may be well known, and that fact may enable someone to pull out their medical record from a database of 50 million others.
You probably can't get around the issue that no data in any setting is absolutely anonymized and secure. But I think the constraints in the system that have already been thought about other types of clinical data are probably pretty secure. And one of the great things about databases is that you may not be able to make it secure, but you can know what everybody's done in the database. So you can track who's done what, who's looked at what, when they've looked at it, what they've looked at, how they've looked at it.
The current plan seems to rely in part on limiting access to the data to trusted research partners, whether in the public or private sector. But some say that's not enough and want the government to make clear the precise details of how it plans to keep our data secure.
What we actually need is for anonymisation mechanisms to be open to the public so that we can see what's happening to our data and we can work out for ourselves whether the protection is adequate. I want to see what those mechanisms are. I want to be able to test them. I want to be able to kick the tires. And if the government's lying, I want to expose them and embarrass them for it.
Bioethicist Stuart Hogarth says he's not sure people are ready to buy in on this one.
The grand bargain that the government's offering us is that if we give them our DNA, then they're going to revolutionise healthcare. Well, it's not clear, in fact, that we need so much genomic data to understand the genetic basis of health and disease. It's not clear that the government has the capacity to put in place a large-scale IT project of the sort that would be necessary to do this. And it's not clear that the British public is actually willing to accept that bargain.
And others think that if David Cameron's goal is to attract life sciences industries to the UK, he should look more widely than the promise of mass datasets. Richard Sullivan has worked in the pharmaceutical industry and was Clinical Director of Cancer Research UK for 8 years.
There's absolutely no doubt the NHS is in a unique position to do all sorts of association and correlation studies between science and patient outcomes. The reality is industry is in the UK because of the excellence of the healthcare professionals and the ability of the NHS to do clinical trials, and it's here because of the creativity and the brilliance of our scientists. That is what industry looks for, not simply a very large data collection exercise.
So before we embark on such big data experiments, whether with the nation's health or some other private information, many people will want to be reassured that they'll have the choice to opt in rather than having to take the time and trouble to opt out. They'll want to know who stands to gain by this trade in data, and they'll want to be reassured that the government has taken the best possible steps to protect sensitive information before it's handed over. The use of big data will grow because it promises so much. But we'll only know for certain who's doing what with the data the government holds on all of us if it's used in a way that's open, testable, and transparent.